Approach to the Diagnosis of Acute Pulmonary Embolism, presented and narrated by Farhad Pirani, 4th year medical student, Faculty of Medicine, University of British Columbia, in collaboration with Dr. Nasir Jaffer, Abdominal Radiologist, Department of Medical Imaging, Mount Sinai Hospital, University of Toronto. The following presentation is designed to provide a framework for investigating patients with probable clinical symptoms of pulmonary embolism. Not all patients will have the classic symptoms, nor will all patients require all the medical imaging studies in the algorithm, but diagnosis should be made quickly so that the treatment is started before significant complications develop. This presentation will begin with a clinical history, followed by all types of investigations, both clinical and medical imaging studies that can be used for diagnosing pulmonary embolism. A 30-year-old woman broke her ankle during a skiing accident in Colorado, and a cast was placed. Upon the return flight home, she began to experience left-sided pleuritic chest pain and mild dyspnea. Past medical history is significant only for heartburn managed by Tums. What is your clinical diagnosis? And what imaging test would you do? A chest X-ray was performed in the emergency department. What are your findings? There is a rounded opacity near the left costophrenic angle, which represents an area of pulmonary infarct and is referred to as Hampton's hump. In the magnified image to the right, this finding is delineated by arrows. When considering the diagnosis of pulmonary embolism, it is important to realize that the symptoms and signs are neither sensitive nor specific. Prior to diagnostic testing, patients can be stratified according to Wells criteria into 3 categories: high, moderate, and low pretest probability for pulmonary embolism based on the clinical history and physical findings listed. This simple model helps guide the diagnostic workup for those patients suspected of having a pulmonary embolism. The investigation of pulmonary embolism includes the use of laboratory investigations and/or diagnostic imaging techniques. Although laboratory investigations for pulmonary embolism are non-specific, D-dimer assays have good sensitivity and good negative predictive value. The various forms of diagnostic imaging include chest X-ray, ultrasound leg Doppler, contrast VENOGRAM, ventilation perfusion scans, CT pulmonary angiogram, magnetic resonance pulmonary angiogram, and conventional pulmonary angiogram. So what is the D-dimer test? D-dimers are degradation products of cross-linked fibrin and are indicative of thrombosis and subsequent fibrinolysis in the body. Only 30% of patients with a positive D-dimer have a diagnosis of PE, as other disorders including MI, stroke, CHF, infection, and trauma can all cause elevated plasma levels of D-dimer. Therefore, although the test has poor specificity, it is routinely recommended in cases where the pretest probability is low, as determined by Wells criteria. If the D-dimer value is less than 500 nanograms per milliliter in these patients, PE can be excluded. The first imaging test we will discuss is the use of chest X-ray in pulmonary embolism. A common misconception is that radiographs of patients with PE are normal. This is not true. Chest radiographs are often abnormal. However, these abnormalities are not helpful diagnostically, as they present as often in patients without PE. The most common findings include segments of atelectasis or an elevated hemidiaphragm on the affected side due to diminished lung volume. Pleural effusions, usually small, are also relatively common. Less common findings include Hampton's hump, which is a rounded opacity near the costophrenic angle indicative of pulmonary infarction. Other areas of lung may also undergo infarction, resulting in localized airspace consolidation. Westermarck's sign is a localized area of peripheral oligemia plus minus distended proximal pulmonary arteries. Lastly, localized pulmonary edema may be a finding, but this is quite rare. Here are chest x-rays of patients suspected of having pulmonary embolism. Can you list the findings? The patient on the left demonstrates cardiomegaly, an enlarged right pulmonary artery, and increased lucency of the right upper lobe. This is a classic depiction of Westermarck's sign of oligemia. The patient on the right has a Hampton's hump, which represents pleural infarct at the periphery of the left lower lung base. If you recall, this was the finding present in our patient at the beginning. In the differential of Hampton's hump, one must also consider a pleural effusion, pulmonary nodule, or round atelectasis. In the evaluation of PE, the lower extremity venous system is sometimes explored for deep venous thrombosis. Today, DVTs are diagnosed primarily by ultrasound leg Doppler, which examines leg veins from the popliteal to external iliac. The key features of this examination include determining the presence or absence of venous flow, the compressibility of veins, the presence of collateral veins signifying chronic thrombosis, and the variation of the exam with respiration. In symptomatic patients undergoing ultrasound leg Doppler, a positive test rules in a proximal DVT, whereas a negative test rules one out. Take note, however, that in asymptomatic patients, ultrasound leg Doppler has poor sensitivity and therefore further evaluation is warranted. On the left is a normal ultrasound image of the femoral artery and vein. In the resting phase, both the femoral artery and vein are visible as hypoechoic areas, with the vein being medial to the artery. Upon compression from the ultrasound transducer, the femoral vein compresses until the lumen almost disappears. Conversely, the femoral artery does not compress due to higher internal blood pressure and a thicker arterial wall. An image of normal venous flow is also shown. On the right is an ultrasound image illustrating acute thrombosis of the common femoral vein. Upon compression with the ultrasound transducer, the vein is not fully compressible. Compare this to the normal compressible image on the left. Although not evident on this slide, ultrasound may also show echogenic material within the venous lumen rather than anechoic fluid, which would represent a thrombosed clot. The venous Doppler image on the right illustrates a partial absence of Doppler signals, which also points to thrombus formation. This slide depicting contrast venograms is of historical interest when DVTs were diagnosed by leg venography. Contrast was injected into a dorsal foot vein, which would result in opacification of the entire deep venous system of the leg in the absence of thrombosis. If thrombi were present, filling defects would be seen as illustrated in the image on the right by the arrows. This imaging technique has now been replaced by ultrasound leg Doppler, which is currently the standard of care. The next imaging technique to discuss is the use of ventilation perfusion scans in the diagnostic workup of pulmonary embolism. In ventilation perfusion scans, a radioactive compound, usually xenon-133, is inhaled and a radioactive compound, usually serum albumin tagged with technetium-99, is injected intravenously. As illustrated, in a normal lung, air will distribute evenly throughout all lung fields, and the radio-labeled serum albumin should distribute evenly throughout the lung vasculature. If an area of the lung is not perfused, but is ventilated, this is termed a VQ mismatch, and the patient most likely has an embolus. Other terms used to describe VQ scans include VQ match, indeterminate match, and normal match. On the right is an example of a normal VQ scan. Note how the entire lung parenchyma is ventilated and perfused with no defects. It is important to remember that a completely normal perfusion scan rules out PE. However, despite the high sensitivity of VQ scans, they have a low specificity, as exemplified by the following slide. In this VQ scan, there is a VQ mismatch of the right lower lobe. However, the patient also has underlying COPD, which causes alterations in ventilation. Other cardiopulmonary diseases, including pneumonia, emphysema, and tumors, can make interpreting VQ scans tricky. Therefore, VQ scans are usually ordered when the chest X-ray is normal, or the patient has a contraindication to CT, such as contrast allergy or renal dysfunction. There are 4 VQ scan patterns. 1. A normal scan indicates an absence of any perfusion defects. However, 4% of these patients may still have PE. 2. A high probability scan consists of 2 or more segmental or 1 large perfusion defect identified in the presence of a normal chest X-ray. Approximately 87% of these patients were found to have PE. 3. A low probability scan consists of small perfusion defects with abnormalities found on chest X-ray or ventilation scan. 12% of these patients will have PE unless the patient has a very low pretest probability or clinical suspicion. 4. An indeterminate probability scan classifies patients with any VQ abnormality that cannot be categorized as high or low probability. About 30% of these patients have PE. Patients within this category will go on to have further imaging either in the form of serial ultrasound leg Dopplers or the next imaging modality which we will discuss, CT pulmonary angiogram. CT pulmonary angiogram has become the imaging modality of choice when suspecting PE. Spiral CT scan with intravenous contrast is both sensitive and specific for PE, helpful in ruling out other intrathoracic pathology, readily available, and safe. Pulmonary thrombi can be detected up to at least 4th order branching of the arterial tree. It should be noted that tiny emboli in peripheral pulmonary arterioles can be missed. However, the clinical relevance of this is still under investigation. Along with CT pulmonary angiogram, CT scanning of the proximal leg veins is also often conducted at the same time. However, leg vein Doppler is still more cost-effective. The CT imaging protocol involves starting an IV in the antecubital vein and injecting 100 cc's of non-ionic contrast at a rate of 4 cc's per second. CT scan acquisition is started 20 seconds after completion of contrast injection. A longer period of time is required if the patient has CHF due to compromised cardiac output. CT scan slice thickness is set at 1.25 millimeters. This is an image of a normal CT pulmonary angiogram. Note the patency of the right and left pulmonary arteries with no observed filling defects. Keep this image in mind when comparing it to the following slide depicting CT pulmonary angiogram images of a patient with pulmonary embolism. These are axial and coronal CT pulmonary angiogram images of a patient with PE. Can you identify the abnormalities? In the axial images on the left, a massive emboli is noted in the superior portion of the right pulmonary artery, appearing as an intraluminal filling defect identified by the arrows. On the right are coronal images of the same patient, again indicating pulmonary embolus of the right pulmonary artery. Note, CT pulmonary angiogram results that are discordant with the clinical picture should lead one to consider pursuing additional imaging tests. The role of magnetic resonance pulmonary angiography in the investigation of PE is limited, although studies have demonstrated that its sensitivity and specificity approach that of CT pulmonary angiography. MR pulmonary angiography does not expose the patient to ionizing radiation and is indicated in pregnant patients and those patients allergic to iodinated contrast. The disadvantages of MR pulmonary angiography is its limited availability, its subjection to motion artifact, its suboptimal resolution, and its complicated blood flow patterns. Despite these limitations, there may be an emerging role for MR pulmonary angiography in the future. Direct pulmonary angiography is the gold standard for diagnosing PE using the femoral or basilic venous approach for angiographic study. The image on the left depicts a large right lower lobe pulmonary embolism represented by a filling defect marked by the arrow. For comparison purposes, a normal pulmonary angiogram is also shown on the right. Although considered the gold standard, CT pulmonary angiography remains the preferred imaging modality as it is less invasive and more readily available, yielding results with good specificity and sensitivity. Diagnostic algorithms for PE have been developed, and one such algorithm adapted from Van Bell will be discussed. This algorithm is dependent on the availability of experienced CT radiologists at a hospital. In CT inexperienced institutions, a VQ-based algorithm for PE can be used. Patients are again stratified based on Wells criteria into low, moderate, and high probability of PE. A VQ scan is then conducted with 4 possible outcomes: a normal VQ scan and a low probability VQ scan with low clinical suspicion are 2 situations in which PE can be excluded. PE can be confirmed in patients with a high probability VQ scan and a high clinical probability of PE. All other combinations of VQ scan results and clinical probability of PE should lead a clinician to pursue pulmonary angiogram or serial lower extremity venous ultrasounds. In CT experienced institutions, patients are first categorized as either unlikely or likely to have PE. This distinction is based on Wells criteria, with PE being unlikely if Wells score is less than or equal to 4, and PE being likely if Wells score is greater than 4. If PE is unlikely, a D-dimer level is ordered. A D-dimer value less than 500 nanograms per milliliter essentially rules out PE, while a value greater than 500 nanograms per milliliter requires further investigation in the form of CT pulmonary angiography. In patients clinically likely to have PE, obtaining a D-dimer level is bypassed in favor of direct CT pulmonary angiography imaging. A negative CT pulmonary angiogram excludes PE, while a positive CT pulmonary angiogram confirms PE. Note that these algorithms are merely guidelines, and if clinical suspicion remains high in the light of negative testing, further or repeat diagnostic imaging may be warranted. Just to review, here are some test cases of pulmonary embolism. Patient A has had a chest X-ray, while patient B has had a CT pulmonary angiogram. Can you list the findings suggestive of pulmonary embolism? Patient A's chest X-ray demonstrates Westermarck's sign of oligemia in the right upper lobe. Patient B's CT pulmonary angiogram demonstrates a thrombus located in the superior portion of the right pulmonary artery represented by a filling defect. For further reading on the diagnosis of acute pulmonary embolism, please see the attached references.